טוב, אז ערב טוב, אנחנו שמחים להיפגש שוב במפגש השני. היום בעצם האורח יצטרף אלינו עוד חצי שעה, פרופסור ג'ורג' הורנבי, שהוא אחד המחברים של ה-Clinical Practice Guidelines לשיקום הליכה באוכלוסיות נוירולוגיות, אנשים אחרי שבץ מוחי, Spinal Cord Injuries וחבלות מוח טראומטיות. אנחנו ככה, דיברנו איתו קצת אתמול ונראה שתהיה מצגת מאוד מעניינת. הוא ביקש את השאלות לרכז בסוף, אבל תוך כדי לכתוב אותם בצ'אט. אם אפשר לכתוב אותם כבר באנגלית אז זה יהיה יותר קל, ואז הוא יקרא ויעבור. ג'סטין תעזור. וזהו, אני מקווה שיהיה דיון פורה איתו ומעניין. ואנחנו נתחיל קצת בכמה עדכונים לגבי המפגש הקודם והמפגש הבא, השלישי שמתוכנן. אז מיכל תמשיך מכאן.
אוקיי, אז שירלי, תעבירי את ה... אוקיי, אני מצטרפת הערב טוב, ואנחנו רוצות קודם לסכם ככה את השאלונים שענו בעקבות המפגש הקודם וגם הקישור שנשלח עוד קודם לכן. אז בסך הכל יש כ-200 פיזיותרפיסטים שהביעו עניין בפעילות של הקבוצה. אני אוסיף שבהערת אגב שבהתאם לזה אנחנו גם משלמים לקבוצת העניין העולמית בפיזיותרפיה נוירולוגית פר 200 פיזיותרפיסטים, שזה בערך $0.50 לפיזיותרפיסט. אז זאת התרומה שלנו לקבוצת העניין העולמית. ובמסגרת השאלון שהעברנו ביקשנו שאנשים יעלו בעצם את השאיפות, את הרצונות שלהם, מה הם בעצם מצפים שיקרה בתוך הפעילות של הקבוצת עניין, וכאן סיכמנו את הרעיונות והצעות ובקשות המרכזיות שעלו. אז אני רק אקריא את הדברים. הייתה הצעה לקיים מפגשים שכוללים תיאורי מקרה, ותיאורי מקרה שיאפשרו גם למידה אקדמית של ידע וגם את היישום הקליני ואיך הדברים נראים בקליניקה, עם דיון על האתגרים שקיימים בתוך הקליניקה ביחס לתיאורים. ובנושא הזה אורית וסילבי ירחיבו עוד מעט. נושא נוסף שעלה זה העדכון והוספה של כלי מדידה מתורגמים לעברית למאגר, שהיום הוא בעצם מין חוברת מדופדפת כזאתי שנכתבה בשנת 2011 בערך, ויש בה עוד כמה תוספות. הדס הוסיפה את הנוטינגהאם ויש עוד כמה תוספות, אבל גם צריך לעדכן את החוברת וגם אפשר להרחיב אותה וגם אפשר להפוך אותה לפורמט אלקטרוני, אינטרנטי, למילוי בעצם של טפסים ישירות לתוך מערכת ממוחשבת. אז ביחס לנושא הזה אנחנו בהחלט קוראות לאנשים שיש להם עניין לתרום לפרויקט הזה של קבוצת העניין, לפנות אלינו ואנחנו נוכל לרכז, לבנות את הקבוצה שתוכל לעבוד ולקדם את זה. נושא נוסף שעלה זה אנשים ציינו תחומי ידע שונים שבהם הם רוצים העשרה, העמקה, וכאן רשמנו את הדברים הספציפיים שעלו, שהרבה אנשים ציינו את הנושא של מחלות נוירומסקולריות, גם עדכון והרחבה בנושא של נחש וטיפול בנחש ו-TBI. אז כאן שוב פעם אנחנו פשוט קוראות לאנשים שהיו רוצים לשמוע הרצאה של מישהו ספציפי בנושא, או הם עצמם היו רוצים לשתף ולהרחיב את הידע של הקבוצה, לפנות אלינו, ובאופן הזה נוכל לארגן מפגש שהם יעבירו. נושאים נוספים שעלו ואנחנו לא שמנו אותם בנקודת הזמן הזאת על השולחן שלנו לטיפול בשנה הקרובה, בעיקר מהסיבה שאנחנו חושבות שהם דורשים מחויבות מאוד גדולה וצוות של אנשים שמחויב אליהם לאורך זמן, הם הנושאים של פיתוח של כלים להטמעת ידע בקליניקה, כמו לדוגמה כתיבה של אמות מידה לטיפול במצבים מסוימים בפתולוגיות מסוימות, או פיתוח של סדנאות מעשיות ויישום שלהם. והנושא השני הוא שכמה וכמה אנשים ציינו אותו, קיום של מחקרים או קידום של מחקרים רב מרכזיים, או בעצם לפתח את השדה הקליני של השיקום בפיזיותרפיה בישראל לשדה כזה שיאפשר מחקר רב מרכזי, שזה גם תהליך ארוך שדורש השקעה רבה. אז אלה תחומים שאנחנו חשבנו שבשלב הזה הם גדולים על היכולת שלנו להשקיע בתוך הפעילות של הקבוצה. לעומת זה שלושת הנושאים שמודגשים הם נושאים שאנחנו חושבים שניתן כבר בשנה הקרובה לקדם אותם ולקיים מפגשים שקשורים בהם. אז שוב פעם, מוזמנים לפנות אלינו מי שרואה, מוצא או חושב שהוא יכול לתרום או לקחת על עצמו לקדם את הנושאים האלו. ועכשיו אני אעביר לאורית שתדבר באופן ספציפי על הנושא של case studies, מפגשי תיאורי מקרה.
הבעיה שלי שהכלב נובח, אז אני רגע מסיטה אותו ואני אמשיך.
אולי הכלב של סילבי לא נובח. בסדר.
סילבי אין כלב.
בסך הכל עד שאורית תתפנה, אני רק אציין שהכוונה שלנו לקיים מפגשים לאורך השנה הקרובה שיאפשרו לאיזושהי התהוות של קבוצה קבועה שמתוכה תיבחר, יש לזה שם, נכון שירלי? איך זה נקרא?
ועדת היגוי.
הוועדת היגוי, שמתוכה תיבחר ועדת ההיגוי שתנהיג את הקבוצה בשנים הקרובות. אז מה שאנחנו מדברים זה על איזשהם מסגרות, איזשהם פעילויות לשנה הקרובה, ופרויקטים לשנה הקרובה. הייתה שאלה בצ'אט. אורית, את רוצה להתחיל?
הייתה שאלה רק, אורית עליון, יש לנו את המידע, אבל לא עשינו פילוח לפי המקומות עבודה, מרכזי שיקום. על פניו היה נראה שמרבית האנשים עובדים במסגרות שיקום, שונות גם בקהילה וגם בתי חולים, אבל נדאג לארגן את זה, זה כמות של אנשים, חלקם רשומים כמה פעמים גם, אז אנחנו נעשה כזה סינון ונעביר את המידע.
אני יכולה להגיד משהו?
כן.
קודם כל, ערב טוב ותודה רבה.
ערב טוב.
אני חושבת שזה מאוד חשוב, כי אחרת אנחנו נשארים מתחת הפנס, ומתחת הפנס זה מרכזי שיקום. ויש עולם שלם מחוץ למרכזי שיקום, ואפילו מחוץ לטיפולי יום, שאני חושבת שחלק מהעולם הזה ממש צריך, ורובו יודע שהוא צריך איזושהי תמיכה, קידום, לא משנה איך נקרא, העשרה, זו המילה יפה. ולכן אני חושבת שזה די חובה להגיע, לנסות, לפחות שהחלק הזה, שאנחנו נגיע לחלק הזה, לא רק למרכז שיקום.
כן, נכון, נכון. אז אולי זה גם עבודה של שיווק, אפילו למפגשים האלה, שהם מפגשי ידע בסך הכל, וגם מפגשים להחלפת דעות ושאלות, אז אולי כל אחד מאיתנו גם יכול לקחת על עצמו קצת את השיווק של המפגשים, ולהתחיל אפילו בדבר הזה שקיים, אנחנו מקווים יהיה קיים לאורך השנה. אבל נכון. אורית? אורית.
לא אני. אני אמשיך את ארוחת הערב.
נראה לי שהיא מאלפת, ועושה לאלף את הכלב.
כן, זה נשמע ככה.
כן.
טוב, אז בינתיים אולי נעשה את הדבר אחרי
כן. כן, אנחנו כאילו רצינו כן לתת מקום, אנחנו כאילו בפעם הקודמת הייתה הרצאה, אנחנו דיברנו הרצאה וסגרנו את הזום והלכנו, ורצינו כן להתחיל דיון קצת או שיחה יותר בין האנשים שבקבוצה, ורצינו לכוון אותה בשלב ראשון את השיחה הזאת עם השאלה שקשורה לאיזה בעצם פעילויות של למידת עמיתים, הרחבת הדעת, התלבטויות משותפות מתקיימים במקומות עבודה, ומה בעצם הדברים שאנשים חושבים כתורמים להם, בכוונה בשביל בסוף לחשוב לאיזה כיוונים אנחנו ניקח את הפעילויות שלנו, של הקבוצת עניין. זה גם מתקשר לנושא שאורית העלתה, כאילו איך אנחנו בעצם באמת תורמים לכלל הקהילה שלנו. אז פתוח לשיחה שמוגבלת בזמן. גליה, רק תציגי את עצמך.
אני יכולה לספר מה קורה אצלנו? כן, אני גליה, עובדת במחוז חיפה וגליל מערבי, ומה שקורה במחוז שלנו זה שכל האנשים שעובדים עם אוכלוסייה נוירולוגית, יש לנו נציג או יותר בכל מכון, ופעמיים, 3 בשנה אנחנו עושים פגישה של צוות העניין הנוירולוגי המחוזי, ושם אנחנו גם מעבירים ידע וגם עושים case studies שאפשר ללמוד מהם. אז זה דרך טובה, אם אורית ליון דיברה על הפריפריה או לאו דווקא מרכזי שיקום, אז זו דרך טובה מאוד להעביר ידע. גם משאירה אותנו, גם נותנת פעולה יחד ומקדמת, ואני מרגישה שזה מאוד תורם לי, ואני מקווה שככה אנחנו כן נפגשים ומשתפים.
גליה, את יכולה לתת דוגמאות? בהחלט, אבל את יכולה לתת דוגמאות של דברים שעשיתם?
כן, בשנה האחרונה היה לנו מפגש...
רגע, גליה, רק שנייה. כן, סליחה, גליה. כן.
אז היה לנו השנה מפגש על טרשת נפוצה, שמכון אחד ארגן, וזה היה גם הרצאה על ידי רופא שעובד במרפאת טרשת נפוצה, וגם היה case study שליווה מטופל לאורך שנים בקהילה. זה היה השנה, היה לנו מפגש שדיבר, כל מפגש הוא נושא אחר, ואנשים עם מספר מכונים לוקחים חלק בהכנה ובעצם העברת הידע. וזה כן תורם לנו, וזה גם קבוצת וואטסאפ שהיא מקום להתייעצות, לדיון הדדי, תמיכה הדדית.
אז קבוצת וואטסאפ זה באמת דבר שאנחנו התלבטנו אם אנחנו רוצים לעשות לכל קבוצת עניין בשיקום נוירולוגי, ואת אומרת שזה פלטפורמה שנוחה לדיון.
היא נוחה כשזה מצומצם, אני חושבת כשזה משהו רחב מדי אולי זה קצת קשה, אבל כשאנחנו בערך אולי 20 פיזיותרפיסטים, פחות לדעתי. אז זה מקום טוב גם להעברת ידע וגם רעיונות אחד לשני ושליחה ומקום לענות על שאלות. כשזה יותר מצומצם זה בהחלט הולך, זה עובד.
וגליה, זה פתוח גם למי שהוא לא בתחום של נוירולוגיה? אנשים עם מכונים
אנחנו, כשאנחנו מפרסמים את הפגישות האלה, זה מתפרסם למנהלי מכונים, ואני מאוד מקווה שהם מציעים את זה לכלל הפיזיותרפיסטים, למי שרוצה.
אורית, חזר?
אוקיי, אם יש עוד מישהו מי הוא לא עושים כלום? זאת המסקנה מהשתיקה.
מיכל, אני יכולה להגיד משהו?
בטח.
שקט. אז ככה, אצלנו אני עובד בבית חולים אקוטי, שיש שם גם מחלקת שיקום, אז יש ישיבות צוות שהם שכל הצוות, גם אלה שעובדים במחלקות נוירולוגיות, אבל גם ישיבות צוות או רואים מטופל רק ששייך לשיקום, של צוות השיקום שרואה אותו, ואני יכולה להגיד ככה מהשטח, גם העבודה בכללית הרבה שנים וגם איפה שעכשיו אני עובדת, יש חסך מאוד גדול של ידע בחבר'ה הצעירים, שתזכרו, לא יודעת מי פה בדיוק בפורום, אבל כשהתחלנו לעבוד בנוירולוגיה, אז אתה הרבה פעמים לומד מאלה שלידך, וכשמגיעים למקומות קטנים לא תמיד יש...
אני אשמח להציג את מה שרציתי, רק תזכרו.
אורית, אי אפשר לשכוח אותך, אל תדאגי.
זה פשוט מאגד, אני חושבת שזה מאגד פשוט את מה שאנשים התחילו לומר.
כן, זה בדיוק מוביל.
עכשיו כשסיימת לאלף את הכלב.
לא, נעלתי אותו באיזה מקום, אבל אם תחזרו לשקט, שאני 5 דקות אגיד, ואז תוסיף.
רגע, אז אורית, ניתן לדפנה לסיים, וזה מאוד מוביל מה שאת אומרת אולי.
ותכף המרצה ייכנס, אנחנו צריכים להזדרז.
אז אני אגיד עוד 2 מילים וזהו. אני חושבת שיש חסך במכונים של הקהילה בוודאות, כמו שאורית אמרה, של ידע, אבל גם אני חושבת במקומות אחרים, הצוות הצעיר צריך בסיס יותר רחב של ידע, במיוחד בחלק המעשי, כי בסך הכל הם עושים התנסות אחת בשיקום, והם באים עם חוסר ידע בעיניי. שזה משהו שאפשר ללמוד, רק צריך לחשוב על הדרך. זה אורית מבחינתי, הבמה שלך.
אז רגע, אני...
תמיד, דפנה, תמיד. מיכל, את יכולה לשים את השקף הזה?
כן, אני אשים לך. הנה.
טוב, אז באמת יצאתי לחל"ת מלוינשטיין לתקופה מסוימת, ועבדתי איפה שעבדתי, ובאמת היה חסר לי כל הצוות הזה מסביב, ולמעשה כשאתה לבד, כמו שאורית אמרה, במכונים, ולא משנה, גם במקום, לפעמים אתה לבד עם הרבה אנשים ואתה רוצה להיות חלק ושותף לידע וללמוד מחבריך, אז אני חושבת שאין כמו למידת עמיתים, וכאן הצגתי את הרציונל, הרעיון לנהל את הדיונים הקליניים שכיום הם בזום, אבל כשנחזור לחיים נורמליים, אז כמובן שאפשר יהיה לקיים אותם לייב, ובעצם חשבתי שא' כדאי לשתף, כי אולי אני לא צעירה כמו הצעירים שסיימו אתמול ללמוד, אבל גם אני מרגישה שיש הרבה ידע שחסר לי, ושיש הרבה חברים שיודעים וכדאי לחלוק. אני חושבת שאם אתה רואה, אם אנשים אחרים מצליח להם, אז נחמד יהיה שישתפו אותנו ברעיונות, בהצלחות. אני חושבת שיש המון פרוטוקולים, שלמשל כשהתחלתי תואר שני בחיפה, אז למדתי כל מיני דברים ממיכל, אבל אולי מישהו אחר שלא היה תלמיד שלה, לא שמע את זה, וזאת הזדמנות תהיה להציג כל מיני דברים שנגיד בהדסה, השתמשו בגרספ, כבר התחילו להשתמש לפני הרבה שנים, כשאני נמצאתי במקום גיאוגרפי אחר, ובכלל לא שמענו על זה, לא בכנסים ולא בשום מקום, הייתי צריכה להגיע לאוניברסיטת חיפה ולשמוע על מה קורה בירושלים. אז חבל. ולגבי איך ניישם את הרעיון הזה, בעצם חשבתי שאפשר לחשוב על איזושהי בעיה שאני נתקל בה בקליניקה, והייתי שמח להסתייע או עם קולגה שלי מעולם הפיזיותרפיה, זאת אומרת פיזיותרפיסט, או באמת מישהו מתחומי ידע אחרים, כמו שאנחנו עובדים בשיקום, ואולי במכון אין להם את המרפאות בעיסוק, את הקלינאיות תקשורת, את הפסיכולוגים, את רופאי השיקום, או את המומחים למאמץ, או את המומחים לתחום של שיקום לב, וזאת ההזדמנות תהיה להציג מקרה, וגם אולי לגייס פאנל של מומחים, כי כל אחד מאיתנו כבר מכיר המון אנשים בתחומי ידע, מובילים בתחומי ידע מסוימים, ואני חושבת שכדאי שנארגן איזושהי דרך, איזה טמפלט מסוים שלפיו נציג את המטופל, ואפשר, אם מישהו יש לו סרטונים, הוא בעצם ישיג סרטון. אני חושבת שבהצגה עצמה זה גם איזושהי למידה שלנו כקלינאים, איך אתה מציג מטופל בפני אנשי מקצוע אחרים, איך אתה עושה את זה בצורה תמציתית ורצינית, עם outcome measure כמו שצריך, ומתאר גם את הטיפול כמו שצריך. בקיצור, אני חושבת שזה ווין ווין לכולם. מעבר לכך, אני חושבת שיש המון אנשים ויש המון ידע, שאם זה לא מילה גסה לומר שלא הכל בטיפול שלנו הוא evidence-based, אנחנו מאוד הולכים לכיוון ה-evidence, זה בסדר, אבל יש גם המון ידע שעבר בין השנים, אנחנו זכינו להיות תלמידים של אליה, ולאט לאט, נכון שיש לה את הממשיכים, אבל לפעמים למדנו כל מיני דברים, ויש לנו את אורית ויש עוד אחרים, וזאת הזדמנות לשמוע גם את התורה שבעל פה. בקיצור, וסילבי ואני נשמח כמובן לרכז את זה, שיש מצד אחד את האקדמיה, מצד אחד את הקלינאית, וכמובן שאנחנו מזמינים את כולם, זה לא את מרכזי השיקום, זה כל העוסקים בדבר, זהו.
אז בעצם המפגש הבא הוא יהיה בנובמבר, ואז זאת הכוונה היא להתחיל עם מפגש כזה.
כן, שמי שרוצה שישלח, אתם תחליטו לאן שולחים, מצידי שישלחו אליי ואל סילבי, אנחנו נכתוב את המייל, וננסה לבנות איזשהו, נעזור למי שרוצה להציג, או שאם הוא לא צריך את עזרתנו, אז תפדל, אבל זאת הזדמנות.
אני יכולה להציע משהו?
כן, ואז אנחנו נתחיל בהרצאה, ממש.
אז רואית, קודם תודה רבה על כל העבודה. אני חושבת שאולי היה נחמד, לאור מה שאורית אמרה, ודפנה ודליה קודם סיפרה, כל פעם להתארח אולי במקום אחר, ושהמקום יביא את המטופלים שלו. אני הייתי דווקא מתחילה אפילו לא מהמרכזים הגדולים, כי זו לא חוכמה. שהמקום יביא את המטופלים שלו, והתמיכה לקייס סטאדי הזה תהיה מאנשים ספציפיים, לאו דווקא גם מהמקום, אבל גם מבחוץ, ומכל הקבוצה הזאת. יכול להיות שזו דרך להתחיל להכניס אנשים נוספים.
אוקיי,
כן, אורית, אז תיקחו את זה בחשבון, את ההצעה של אורית.
כן, אנחנו נדבר עם אורית, זה קצת מורכב, ועם כל היום, עם כל הסודיות הרפואית, ומה מותר ומה אסור, אנחנו נחשוב איך לעשות את זה, אורית.
מעולה.
אני זוכר 10-12 שנים אחורה שזה נעשה, זאת אומרת, היו כאלה מפגשים שאני זוכר שהייתי באיכילוב במפגש כזה.
נכון, זה היה
זה לא, אנחנו לא ממצאים פה את הגלגל.
לא, אבל לא ראינו מטופלים.
ראינו קצת, אבל רגע...
טכני.
אורית, רגע, אז עכשיו אנחנו צריכים, אורית וסילבי ימשיכו לפתח את הרעיונות ויהיו בקשר עם כל ההצעות.
ונדבר עם אורית היום.
מעולה, ואנחנו נחזור לשיר שתציג מרצה ונעבור לקור שלנו, ותודה על השיחה, ותמיד כיף לדבר.
I'll change to English, and good evening and good afternoon. I am happy to introduce our guest speaker, Professor George Hornby, from the Department of Physical Medicine and Rehabilitation at Indiana University School of Medicine. Professor Hornby is the director of the Locomotor Recovery Laboratory at the Rehabilitation Hospital of Indiana. He received his PhD degree in physiology and neuroscience from the University of Arizona, a master's degree in physical therapy from the University of Pittsburgh, and a postdoctoral fellowship at Northwestern University. His research focuses on the mechanisms underlying the loss of strength and coordinated functional behaviors following neurological injury and development of strategies to ameliorate these deficits. His recent studies are directed toward knowledge translation and implementation to improve clinical treatment of patients with stroke and spinal cord injuries. Welcome, Professor Hornby. Thank you for being with us. And
thank you.
Zoom is all yours.
Okay, I don't know Hebrew, so I apologize. Please bear with me. Let me just share my screen. Okay, so Shirley asked me to talk. Again, thank you for inviting me to this talk. The talk I'm going to give is from a version that we gave at the Combined Sections meeting in the America in 2020. Sponsored by the APTA, and I'm just going to give a brief part of it because of time, but it's entitled Removing the Kid Gloves in Neurological Rehabilitation. Before I start, just wanted to thank the numerous therapists and other researchers who have helped throughout my career and the funding sources on the bottom right that we have right now. So we are going to talk about a brief introduction and then the actual data, why you should remove the kid gloves. Application to real world environments, I probably won't get to this. I'm happy to answer questions about it at the end, and I do have some references for you. All right, so if we think about physical therapy, we have gone through a pretty substantial trajectory over time, and the way we think may have changed or may not have. And there's been Sherrington and reflex theories that have propagated into NDT, Bobath, and Brunstam approaches. There's PNF-RUD, which kind of harness some of those reflexes. People got really into task-oriented training, the idea that the brain and the spinal cord can change with certain tasks. And right now we're doing kind of adjunctive therapies. What else can I add on? Now, therapists nowadays may not believe in any single one of these things completely, but a lot of us take some parts of these that we've learned over our years and we hold on to them as truths. I just want to talk about some of those truths that people believe that have lasted throughout the years. So common themes of neurological therapy, education, and practice, that if we have deficits in impairments like strength and balance, if we target those, they should improve function. So this is just a graph showing how that balance and strength is related to walking function. This is spinal cord, but the same data holds true for stroke, and there's multiple studies that have shown that. So if I address those impairments, function should come along for the ride. The other idea is that I need a standardized progression of task difficulty to prepare for advanced mobilities tasks. So Anne Gentile had this movement taxonomy where you really want stability before mobility and limited variability in constrained environments before you move to variable and unconstrained environment. And we progress that, and that's, we see that all the time. Like you can't stand before you can sit well, and then if you stand, then we're going to do pre-gait, and then we're going to do pre-gait, and finally into walking. And then the idea that normalizing movement practice can best promote functional recovery, that the sensory information retrains motor output and perfect practice makes perfect. So we provide normalized movement, and sometimes it takes a lot of therapists to do. And then conversely, practicing abnormal movement reinforces abnormal patterns. So because they've had a stroke, they may have a risk of injury, turning their ankle, bad knee, bad hip. They put more weight on their non-impaired leg versus impaired leg. And these individuals with stroke, well, they have a cardiovascular risk, so we don't really want to work them hard. Plus, they will actually, they will increase their spastic motor behaviors temporarily, and then they'll certainly not look good. And the idea is that we reinforce these patterns. So those are these kind of tools in these toolbox that we have. And whether you, my button's not working. These tools in these toolbox, and whether you are these beacons of rehabilitation, these really large hospitals, these smaller hospitals, or you work in a nursing home or the physical therapy clinic between the sandwich shop and the mailing place, these are the tools we rely on. Over the past 20 years, there have been a number of more tools. There's exoskeletons to move the legs. There's elliptical devices that are motorized. There are devices that will push and pull upon the trunk or anywhere you want. There are devices that will follow you along as you walk. There are devices that hang over and follow you as you walk over ground. There are virtual reality. There's air pushing you up on a treadmill. There's water pushing you up on the treadmill. And then you have more tools, the exoskeletons like the Rewalk, the Indego, the Exo. Honda has a robot, Toyota has a robot, Hyundai has a robot. Sorry, I hate when they do this. All right, sorry. These are robots, not cars we're talking about. And if you work on those really big clinics, you might be able to actually afford some of these tools and have them available. If you work at the smaller ones, you may not have as much, but if you work at those really small ones like nursing homes and the clinic between the sandwich place and the mailing place, you have no shot at those. And so what do? You fall back on your standard tools. The problems we have aren't unique. The idea is that we want to make the best outcomes for the least amount of money. Every field of business, marketing, economics, they all rely on value and efficiency. One of my favorite examples is in sports. So many of you may have known this movie. It's called Moneyball. It's from a baseball book back in 2003. The movie came out in 2011. The general manager's name was Billy Beane. It was a story about the Oakland A's, which is a small market baseball team that was really close to the championship. So think of them, for example, as an Israeli soccer team with limited resources, Hapoel Be'er Sheva. I had to ask someone to pronounce that for me. And they are going to lose their players because they can't afford them anymore. So these key players with expiring contracts were heading to large market teams like Maccabi Tel Aviv, which is the biggest team and has the highest payroll. So the idea was, how do I replace players with the same resources? So traditional old school approaches did things the way everyone else did all the time, and they relied on that. But there was this upcoming surge of using data and stats, evidence and science to really figure out what's the best way that I can actually get my team the best with a limited amount of resources, because I don't have any money. And the whole movie is essentially about that and changing the process and getting away from old school traditional and using data and statistics. And I'll encourage you, I'll have this link at the end. The entire talk is at this website, knowledgetranslation.org. It's free. Just look to the videos tab and it talks about this whole story in more detail with some videos. Anyways, trying to think about how do we use science and evidence in rehab? How do we get the best value for our money? In 2008, Jeffrey Klimes and Teresa Jones published these 10 principles of neuroplasticity. Some of them are a little redundant. Some of them are actually are opposite each other, but there are 4 certainly that we can utilize that may be really important. So specificity, repetition, intensity, and salient. So what you do matters, how much you do matters, how hard you do matters, and is it important to the person also matters. If we think about standard neurological physical therapy practice, well, if you're working on walking, we do a lot of traditional impairment-based strategies. That's not specific to walking. And you're not getting a lot of repetitions of walking. And that's really any textbook that we look at still holds these kind of ideas intact. If you look at data, objective data in spinal cord injury and stroke, Catherine Lang in 2009, Kimberly in 2010, and Zogar, we don't take a lot of steps in our sessions. We get limited amount of practice during inpatient rehab or outpatient. And if you look at how hard people work, looking at aerobic intensity, there are a number of studies in stroke and spinal cord injury over the years that said, look, patients in rehab do not work hard. So they don't work a lot, they don't do a lot of specific, and they don't work really hard. Right? That's really going against those principles that we kind of have known for a little while here. All right, so in 2010, these principles had already come out and we were thinking about these anyways and why people don't get better therapy and why they want to improve more. So Jenny Moore in my lab did a study trying to figure out why patients plateau. And the idea here was that these patients would come to our lab for a separate study, and they couldn't be in PT at the same time. And we said, okay, why were you discharged? And they said, my therapist told me I was no longer getting better. So we said, okay, we'll get you in the study. And they did the study, and either group got better, one more than the other, but both groups got better. So what's happening in regular rehab? So Jenny did a study where she looked at patient activities and outcomes during the last 4 weeks of PT. So these are patients with stroke. It's more than 6 months post. They had to be discharged because the therapist said they weren't getting any better. And we compare that to activities and outcomes with 4 weeks of high intensity treadmill walking. So we put them on a treadmill, put them in a harness, didn't help them only if they needed it. And only one person needed help to walk. And we targeted 85% of heart rate max. So trying to hit the highest safe intensity and just walking. We put monitors on their legs. So everyone has a Fitbit now. Those are kind of toys in research. This is an accurate monitor. The stepwatch, this is a record of when an individual was in regular PT. This is a record of 24 hours, and steps per minute throughout the day is registered. The green bars indicate when they're in PT, and they're not doing a lot of steps and not much more than they're doing regularly. If you look at when they're in the locomotor training, one session on the treadmill, here's throughout the day, but you see the density of steps during that hour when we just took them on a treadmill. Huge difference in the amount of steps. If you look at clinical PT in black, mean steps per session, and locomotor training in gray, this is just sticking them on a treadmill, we got about 4 times more steps just sticking them on a treadmill, 900 to about 4,000 steps. If you look about what they do in the real world, so we looked at mean steps per day change, how much they improved out in the real world. They improved by minimal amounts, 0.03%, 24 steps per day after clinical PT, and they improved by 900 steps per day after just sticking them on a treadmill. People think about exercise as medicine. And if you think about, if that is true, then your dose on the left side should be related to your response on your right. And if you plot that, the changes in mobility steps per day were related to steps per session. It is a consistent finding that we had the first time here and in subsequent studies. So here's specificity and amount. So some people would say, okay, what about all those walking trials that failed? Like the LEAPS trial, the locomotor experience post-stroke. There was no difference between walking and non-walking training. Well, heart rates were actually in that study kept purposely low, below 110. And we actually get heart rates higher than that just doing a 6-minute walk all the time. Well, what about robotic devices? Some of those have failed. Well, oxygen consumption and heart rates are lower during robotic training versus PT assist as needed. And there are some old studies in spinal injury and even new studies in stroke with new algorithms for robotic assistance, and people always relax. Intensity is probably pretty important. All right, so you stick someone on a treadmill and their last days have done that, but you have gains a 6-minute walk, but you have limited gains in speed, balance, transfers, and only one study had step per day changes. So what gives? Why is that so good? Well, it may not be great for people who are ambulatory. Treadmill may be good for non-ambulatory patients, a couple studies by Luis Ada and Catherine Dean, but it's not really different from ambulatory. But we really want to consider, what do patients have to navigate each day? They have to go over ground, bumpy surfaces, uneven compliant surfaces like grass. They have to jump over things. They have to avoid dogs. They have to go upstairs. All this variability is what we have to deal with. And those are tasks that are probably important to them. So this is where saliency becomes really important. Maybe we can do the intensive, high intensity training that's task specific, so walking, in environments that are variable and things they have to do every day. So we tried to combine that in a group of studies. So the first study was 2014, a pilot study, had a couple publications from that, really emphasizing all 4 of these. The saliency and the variability are kind of added in. These are just some videos of patients walking, and I'll get to them individually here in a little bit on separate slides, but it is really just pushing them as hard as they can go within safe limits and doing variable tasks over ground, over stairs, as much as we can. Okay. When we did that study, a small randomized trial in subacute stroke, we compared experimental training with control. Control was a regular PT, the same number of sessions, and we just did regular PT activities, strength, balance, transfers, some walking. Didn't get the heart rate up. Experimental was pushing really hard. We've got a threefold difference in outcomes. This is self-selected walking speed. We had the same changes in 6-minute walk. This is the very intensive early walking post-stroke study, the VIEWS trial, 2016. Again, a dose-response relationship. All right, when people look at that, they say, great, but what about balance and transfer? So what we measured was Berg and sit to stand, like many of you do. And what we saw was that even though we didn't practice balance and transfers, they actually improved just the same as a control group that did practice balance and transfers. So basically, we got 3 times a gain in walking, and we didn't practice those other things that people did. We got more walking practice. Those other things came along for the ride. We didn't address them. And we did that. I mean, that happened probably for specific reasons because it was so variable. Going upstairs will probably help with their sit to stand because it's biomechanically similar. Doing a lot of very dynamic balance walking tasks during walking probably helped their Berg, even though we didn't specifically work on standing balance. Okay. So here's some more data on why this stuff may be important. Talks about a new study we did, talk about a new study we did in 2019 it was published, but I'm just going to give you some background about what this protocol looks like. It is not just walking people around. There is actually a strategy here. It's not so much a physical strategy like we're used to thinking in PT. It's more of a mental strategy. Like what are their deficits and how do I figure out how to improve them? So of the deficits that are really important to get someone from point A to point B, Art Kuo and Max Donaldson published a study in 2010 that talked about a lot of biomechanical studies prior to that about the 4 determinants of walking. One is propulsion. That means going in some kind of direction. Limb swing, so getting your leg forward. Stance control, so not collapsing at your knee or your hip. And then lateral and frontal stability, so not falling over like a tree. So based on those 4 subcomponents, we defined it successful walking as going in a specific direction, not stepping in place, a positive step length, limited trunk collapse. So if they needed help, we'll hold them up. If they didn't, we would let them bear as much weight as possible. No one walks with weight support in the real world, and then maintain upright. If they're falling over a little bit, we'll hold them up. And if they can do it on their own, maybe we'll start pushing them over a little bit to get them to adjust their postural strategies. All right, success in our protocol for the experimental group was continuous walking. Failure was 3 to 5 consecutive errors, where they couldn't do it for 3 to 5 times. We'd make it easier for them. Other than this, we did not care what they looked like. We braced their knees or braced their ankles to make sure they were safe. We made sure there were harnesses on them, but gait kinematics were not a primary concern. And so this paradigm here on the left kind of describes globally what we're trying to do. Let's say you have some kind of skill you're trying to do. So on the x-axis is degree of skill acquisition, and on the y-axis is amount of assistance or amount of errors. Now you can take a whole skill of walking and just look at that, but it might be easier to just think about leg swing, limb swing advancement. So let's say you're really bad at getting your leg forward, early post-stroke or spinal cord injury. So you're down here on the bottom left of this curve. You need to give assistance. Like there's no other way for them to walk other than you kind of helping them. You can do that mechanically with a device. You can do that with you going down there and helping them. You can do that with elastic rubber bands, just pulling forward on a treadmill. Once they start doing stuff on their own and go further on this x-axis to the right, then you stop dropping off that assistance. You take away your assistance so they do more of the work. That becomes assist as needed, pulling away from full guidance. At some point, hopefully, they get better at the task and they do it unassisted, as long as they can get their leg forward, not looking pretty necessarily, but just getting their leg forward. And then you start increasing the difficulty, the error augmentation. And the error augmentation would be things like a leg weight or pulling backwards on their thigh. And those types of things would get them, the patient, to actually drive their neuromotor system harder use more force in hip flexors to get that leg forward. That is called error adaptation type strategies. And that has a lot of data for a lot of different types of behaviors that we can harness in our patients with stroke or spinal cord. So if I think about this, I'm going to show you a couple videos of gentlemen in the very initial study. A lot of these guys have multiple things going on, but I'm just going to try to pick out one specific thing that I want you to look at. We will address all these things in a session, but sometimes one more than another. These videos are just focusing on limb swing, okay? So this guy in first session of testing, I'm moving his leg forward. Yes, he's got body weight. I'm holding him up. I'm making sure he's safe, but I'm just focused on that swing. So I'm going to stop this. Yes, we've got weight support and a harness. He's got tethered ropes around the trunk to keep him in place. We also have, again, focusing on limb swing, a rubber band type device lifting forward and up on the treadmill. So when his leg comes back, it pulls forward and I'll help. And so he needs a ton of help just to walk right now. And just, I'm going to focus on this limb swing. This is kind of guidance, just getting him to just get in the ballpark of walking. He gets better, he recovers a bit. So we take some weight off, he's doing well. We're letting him do it on his own. This is just unassisted for the most part, but we put some weight back on him and now it's harder for him to weight shift. So now we've got to help again. So you're kind of manipulating these biomechanical subcomponents as you can to get them to do the tasks that they should do normally. Going upstairs is a great way to increase limb swing advancement. So yes, we try to get him up to the next step, but he's pretty big and we only get to one step. I also show this video because she is a third the size of him and she can pull this off. And then as he progresses, and he's really impaired individual, we've got a 20-pound leg weight on his leg as he's pulling forward. I am pulling him forward, but he is actually doing the work with that leg weight, getting him to do more. This is another gentleman who has a lot of things again going on. So we're going to work on stance stability, so not collapsing, and propulsion. So trying to get him to go fast. This is his first minute on a treadmill. We've got a heart rate monitor on him, so his heart rate was really high. Here is a few days later, and I'm trying to drag him down the hallway here. He can swing his leg forward, so I'm not helping with that. Yes, he circumducts, but he had really no ability to bend his knee. This is him working on going fast up the stairs. So we're working on him not collapsing and using his knee extensors and hip extensors, but really trying to push harder. I'm helping with swing if I need to, controlling the other things, making him do the work for a specific task. Stairmaster is hard for anybody. You take a patient with stroke and he can do this with some time and some practice. And then same individual, let me back up. He is walking at this point. This is the eval. He will fall over like a tree, and that is really his major problem. So we're going to work on lateral stability. Here, Carrie Holland, a therapist in the lab, is just letting him figure out. She's not working on speed, just letting him try to keep his body upright. Abby, another therapist, is working on foot positioning and balance beam. I get that no one actually walks on a balance beam in the real world, but if you can do that, a nice level surface is easy. He was really good at a mat, just a level mat, so we folded over 4 times and made it harder for him. He's struggling, but he can do it. But then here's trying to go up the stairs, having him not hang on to the handrail because we're making him try to maintain balance. Yes, he leans and cheats a little bit. All people kind of cheat. And then last individual, higher level guy. This is his first few minutes on the treadmill. He just walks slow and we're just going to work on propulsion. So instead of us dragging down the hall, we're going to have him drag us down the hall. So he's pushing as hard as he can on the right paretic limb and both sides, but really trying to give him verbal cues to drive that paretic limb. Going up inclines and stairs are also good ways to increase propulsive demands. Really speeding the treadmill up. This is his first shot at running, about 4 weeks into the training, and then his last shot at running coming up here. Same exact paradigm in all 4 of these individuals. 2 were really impaired, 1 was higher level, but it shows you the types of tasks that we're trying to do. So in this new study called the Vibrant trial, the very intensive variable repeated ambulation trial published in 2019, the goal of the study was to examine the relative contributions of stepping intensity and variability on outcomes in individuals with chronic stroke. So really, do you really need to push them hard, or can you just do the variable tasks? Or do you really need all that variability, or can you just walk them really fast over ground? So the hypothesis was high intensity stepping in variable contexts, over ground, stairs, using that kind of curve to guide and augment errors as needed. That would be better than high intensity stepping, just only going forward only on a treadmill over ground, or low intensity stepping in variable contexts, doing all the kind of the crazy stuff. All right, inclusion. These are individuals greater than 6 months post-stroke, unilateral hemiparesis, had to walk at least 10 meters on their own, but at speeds less than 1.0 meters a second with their customary brace and assistive device. The bracing had to be below the knee. Exclusion criteria is like additional neurological or orthopedic injury that limits walking, any type of cerebellar disease, currently participating in PT. 97 patients were randomly assigned to 3 groups. 90 completed at least 10 sessions. They were all similar at baseline, and each received 30 one-hour training sessions in about 2 months. All right, 3 groups. Here is a pretty low-level individual. Remember, she walks on her own, but she's very slow. She's doing the high-intensity variable stepping. The target intensity is over 70% of the heart rate reserve, and getting 15 or greater on the ratings of perceived exertion. So it goes from 6 to 20, 15 and above is hard, trying to get up to very hard. This is the paradigm. We did forward treadmill walking for 10 minutes. We did variable walking, so stepping over obstacles backwards. We went on stairs, and then we did overground training as well. This is her on a treadmill doing forward walking. Remember, really low level, but she is really pushing it. We do have a heart rate monitor on, having her try to go backwards. You can see the heart rate on the bottom there. He's trying to step over obstacles, sometimes not successful, sometimes is successful. And then going upstairs, really trying to push as hard as she can, going up those stairs, letting her do as much work as possible. Again, pretty low level woman, doing better actually now, not that low level, but going up a Stairmaster. 10-pound, maybe 20-pound weight on her paretic limb, going over obstacles and going on a balance beam. All right, this gentleman was in the high intensity forward only group. So same intensity levels, but just walking forward on a treadmill and walking forward on over ground. This is him on a treadmill. He's pretty low level as well. You see the heart rates on the bottom there. And then here they're going over ground. He struggles with collapsing quite a bit. In this paradigm, we could not focus on that. We're just walking them. And then this last individual, he is actually much higher level. He's close to one of the higher functioning. So he looks like he's doing the same types of tasks, and he is, but that heart rate is really low. So we're keeping that about 40% heart rate reserve or less, and keeping the RPEs over 13 or under 13. So again, doing variable tasks, but really low intensity, monitoring heart rate as we go. All right. So if you look at the demographics and training sessions, demographics, they were similar across groups. Sessions, they were exactly the same across all groups. Duration per session, we wanted to target 40 minutes of walking. We only got 33, 34 in the high intensity groups. A little more duration of stepping in low intensity because they had less rest breaks. If you look at intensities, the percentage of heart rate reserve was 60 to 61. So beta blockers were prescribed to these individuals. It was really hard to get them up, but their RPEs were high. If you look at the low intensity, much lower heart rates, much lower RPEs, significantly different between the high and the low group. If you look at steps per session or steps per minute, you get you get a lot of steps in 40 minutes of walking with high intensity forward. You got 3,000 steps per minute, or steps per session, about 75 steps per minute. When you do the variable tasks, you get a bit less walking practice. And when you do the low variable, you get even less practice. All right. So there is differences in the amount of steps that people actually get. If you look at outcomes, These are changes in self-selected walking velocity at baseline. This is change, so it's 0 at baseline. The change at post after 30 some sessions, 27, and then at follow-up, a 3-month follow-up. This is self-selected walking velocity. This here is 6-minute walk. So the high variable group is in purple, the high forward group is in red, the low variable is blue, and you see large differences between the 2 high intensity groups and the low intensity. This dotted line indicates the minimum clinically important difference between the groups, and actually there was a huge difference between the groups that was above this minimally important difference. If you look at 6-minute walk, same basic thing. The difference between the 2 high groups and the low groups was greater than the MCID. Secondary outcomes. We didn't focus on walking. They improved their gait symmetry and kinematics and kinetics primarily with the high intensity training. And that was published in a couple studies in 2019 and then 2020. Other things, gains in balance and balance confidence. The people in the high variable group, the people that did the high intensity and the kind of the crazy stuff, focusing on error augmentation, they're the ones who had gains in balance using the FGA and balance confidence using the activity-specific balance confidence scale, only in that group. So again, you get great gains in walking outcomes, and balance, in this case, balance confidence comes along for the ride, even though we didn't explicitly practice balance tasks except in the context of walking. And then just submitted to PTJ or resubmitted in the revision, we had gains in community mobility, what they did in the real world, only with high intensity variable training. So just walking fast on a treadmill and overground isn't enough. We try to simulate the tasks that have to deal with the real world. So when they get out in the real world, they'll actually deal with those tasks a bit better. Again, this is, I think, the 6th or 7th study that we have that shows a dose-response relationship. This is steps per minute and changes in self-selected velocity or changes in 6-minute walk. There is a relationship between how much steps per minute you got and how much you actually improved. The high forward group was not different from the high variable group, even though there are slightly more gains and more steps. But remember, the gains in balance and balance confidence with the high variable group really gives you more value and efficiency with your outcomes, multiple outcomes. All right, so we've done a few studies, and I don't have a ton of time, but so the idea is of like, let's go back to those theories. Like, do I have to target impairments in body structure and function? Well, recent clinical practice guidelines indicate those tasks don't transfer to walking gain. And in fact, balance, and previously I didn't talk about the strength and transfers, tend to improve when even if you don't practice them. And we have studies in stroke and studies in spinal cord injury that when we really focus on in targeting impairments, strengthening tasks, balance tasks, transfer tasks, aerobic training on a cycle or a recumbent bike, those did not translate at all to walking. The group that walked really improved their walking outcomes. If you look at other theories, standardized progression of task difficulty, well, balance, transfer, strength all improve with high intensity training and variable contracts. Here are some references: Straube 2014, the subacute randomized trial 2016, and then the stroke study that I just talked to you about. And then practicing abnormal movement reinforces abnormal patterns. So gait symmetry, kinematics all improved with high intensity training. So I've given you some old data from Mike Lewick and working in the lab, 2017, data from the subacute trial, the Hornby 2016. We analyzed kinematics. Kinematics improved dramatically with the high intensity training. And then these 2 studies were part of the more recent study that we just talked about, looking at kinematics and kinetics. So you mean reinforcing abnormal or practicing abnormal doesn't reinforce abnormal. They learn new strategies and adapt. So it's really time to kind of rethink some of our tools. Maybe we shouldn't be doing and or teaching some of these things that evidence over the years has shown not to be as valuable as we originally thought. When I grew up in PT school, I certainly did those things for sure. And I got out of school and I started doing them and started then collecting more data. I was like, okay, maybe maybe I was wrong. Maybe these things that I believe don't work. And that's really hard for people to get through. The application to the real world, I'm not going to talk about it. I'm certainly going to show you a slide here in a sec, but in our field, and really in all fields, rehab, I feel like it's more so, maybe I'm just too invested in it. We don't do a lot with the research we have. So the latest research shows we really should do something with all this research. Researchers publish these articles, and therapists oftentimes don't have time to read them or digest them, and it just doesn't translate to their clinical practice. So we need to make large-scale changes in the way we do things, which is really hard. Not unlike the Moneyball story. So what happened in that story, and you can see that on the the link here, the knowledgetranslation.org, the full course that we originally gave is retaped here. But it really, the Oakland A's became a really successful franchise at a lower cost using science, using data and analytics. And they were able to win as many games as the big name teams that spent all that money. But really, it wasn't a story about success. It was a story more about the difficulty of changing from what people do all the time, changing from tradition. That is really hard. He got a lot of pushback when he did this, and the story covers that. When you try to apply what we've just talked about clinically, it is really difficult. Like, there is a lot of pushback. You're challenging what people have done for decades. Like, they learned it from their friend or their colleagues, and they've passed it on. They teach this way, and they've done this for years. Those are hard things to get through. It is difficult, but it is absolutely possible. So we were able to pull this off in Chicago in inpatient rehab, and that's published in 2015. Just published a study last year about trying to implement this in Oslo, Norway, a couple sites stroke units there. That's published in 2020. And in Indiana, my colleague Chris Henderson is writing a manuscript now about how we tried to do this in Indiana. There are a lot of things that help with that, and I can talk about that at the end, but I think that I will stop there. The rest of the couple slides just talk about that. A couple slides on the implementation, but I think giving you some time to ask questions might be helpful. I'm going to stop share, and I'm also going to go to the chat box, and I can answer questions that are in English. And if you do have questions that are not in English, Shirley is going to help me translate. All right, let me just read these real quick. All right, fine motor skills monitored during after training is a trade-off between increased effort. There is not. So effort so if you're talking about upper extremity tasks, the harder you work with upper extremity, the harder you work, period, the arm will go into the synergy, right? So the hand is very different from the legs. So when we talk about intensity in hand, it's not really the heart rates that are important. It may be just the tasks. That said, there are algorithms for predicting upper extremity recovery that the hand has certain limited changes that may occur over time. I'd encourage you to look at the data from Catherine Lang from 2016 and data from particularly Kathy Stenier in New Zealand. I'll just type those names out, Kathy Stenier and Catherine Lang. They have studies on the ability for physical therapy interventions to change behaviors and the limited recovery that we have in the hand. So I don't focus on hand in part because of that. Have you seen subpopulations gaining high outcomes? Yep. So almost everyone has some kind of spasticity. People have sensory impairments. They have neglect. They have every person with a stroke has a comorbidity. So all our studies have these issues in large part, and these individuals do well. I will say that the individuals who are older don't do as well, but that's well established. But there is a woman, and I'll put here, Danil, 2017. So Margaret Danilovich did a study with me. She went to nursing homes with frail elderly, people who are classified as frail, and she pushed them as hard as she could go, and she had these great outcomes. She's now got a large randomized trial that partially got hit by COVID, like we all did. But that one in particular, because all the nursing homes are shut down, but she is trying to work on submitting that data soon. So really frail individuals, coupled with a stroke, she did really well. Upper extremity function is not monitored, but these individuals are treated separately, and there were gains in upper extremity function that were no different from regular training when we had this. This was the 2015 article. So I can get you a paper on that if you email me separately, and email separately is that. What about precautions with cardiac patients in high intensity? So we had initially a moderate intensity protocol in inpatient to see if they tolerate it, and finally just jumped to high intensity training for almost everyone. If the doctor is seriously concerned about their cardiac status, they'll recommend going down. But we have not had one issue here in inpatient rehab or previously in Chicago that was related to the training. It just doesn't happen. We use ACSM recommendations 2017, and then just published 2021, that talks about the heart rate thresholds for cardiac patients. And we use that for our patient population in stroke. What about recovery versus compensation? Okay, good question. There is a paper that discusses exactly that, NNR 2019. It is in the title, recovery or compensation. These individuals, when you push them through, they use their paretic limb much more, and more so than just high intensity forward. So if you're just walking them on the treadmill, they tend to compensate a little bit. If you're really pushing the variability and you're targeting their deficits in swing and propulsion on that paretic limb, then you're targeting recovery. And that study, the other one that's helpful to that is same author, Marzia Anarstani. Both those papers talk directly about this. And that's why we ran the study and analyzed kinematics, so we wanted to answer that question. So these are actually why I do these studies, because I know that individuals who treat these patients have these specific questions, and getting this information to you guys and telling you, these are the clusters we deal with, and the issues we deal with, the same ones you deal with, that helps you actually translate. And that's a large reason why I switched the focus of my studies 10 years ago to start doing this. Any other questions? That was quick, but I only had 45 minutes. Did you follow the participants' mobility in everyday life and natural environments? So yes, not published yet, not yet published. Look for in PTJ, hopefully. So I just resubmitted the article that looked at community mobility, what they do in the real world, like that first study by Jenny Moore did in 2010. So we have monitors on their leg. We monitor steps, what they do during therapy, but also before and after outside in the real world. What we see is significant gains in community mobility, actual stepping in the real world with the high intensity variable training more than the other groups. But really at the follow-up, when they are able to adjust to a new normal and they get a walking pattern in place, that's when you see really good significant gains that follow up with this group. So that will be published. I'm happy to talk about that if you email me separately. Do all patients undergo a stress test before starting training? In our studies, we do, but we don't reach very high heart rates because they have gait mobility impairment. So we're monitoring them, looking for what kind of cardiac events in the research, the controlled studies. In clinical practice, the physicians utilize their records from inpatient, from their acute stroke initially, and monitor whether they should do high intensity, like almost everyone does, versus a small population gets moderate intensity. So we do not do stress testing in the clinic. We definitely do it in the research lab, but the clinic has been doing high intensity here since 2018, or really trying to implement it. And again, Chris Henderson is working on that data. So I know that people get really nervous about this. I just talked to a group of Norwegian physicians, and I gave them all the details, not all, it's a big book, the details from the American College of Sports Medicine and their guidelines for cardiac practice. There is a risk to exercise, but the benefits far outweigh those risks. How do people with sensory deficits act in this protocol? They do well. There's probably more attention to visual information that they need because they can't feel their leg as much. So literally kind of looking down if they need to. And if there's dense, really dense sensory loss, then that visual, cueing is going to be really important. A lot of them have some sensation, and so those are easier. You really see deficits in these individuals when the lights are low or they're blindfolded. So sometimes we'll do eyes closed type tasks to try to accommodate them to get them to accommodate as much as possible. These things are not trivial, but they're workarounds that we've had to do with a lot of our patients over the years. But just because they have a sensory deficit or spasticity doesn't mean you shouldn't do this. Sensory deficits and spasticity are not the primary determinants of recovery. It is strength and balance. All right, do you think they differ from, say, patients treated during the 80th? I'm sorry, the 80th, you mean, Shirley, do you know it, this 80th, the second to last question?
Yeah, I think that the 80s from the, these are different, right, Simona? Different in terms of return to work and return to community. I mean, participation measurements.
Are they 80 years old, you mean?
No.
Let me say it. I meant, do you think that those, let's say, patients or subjects that you treated and others today, do they differ from those that were treated during the 80s or the 90s of the 20th century?
Yes, absolutely. So, gosh, when I came here in 2016, it looked like 1985. No one was walking, no one was doing anything. When I went to RIC, Rehab Institute Chicago, now Shirley Ryan, in 2000, I didn't understand why they were ranked #1 because the therapy was old school. And I had grown up reading papers about how that old school stuff was old in 1990. And 10 years later, everyone's on all the mat doing 4-point. And I was like, no, that's not what the data says. And now we're 20 years past that. And there's even more data that says we shouldn't be doing that. But it's really tough because we're taught that in school, and therapists, students go out and they learn that from the clinician, and they have to pass their clinical. And to tell them that may not be the best way is a tough pill to swallow. For limited budget, what would you consider essential equipment? A treadmill with a harness. It's not that costly. You have some kind of budget. We're looking at $12,000. You can take the treadmill harness, a light gate, for example, over ground as well, and then do overground things. That is the first thing I can get. We were fortunate to get other treadmills that are a little bigger and more sturdy, but just a basic treadmill is absolutely essential. And then gait belts, and then also heart rate monitors. Like $100 polar heart rate monitors are really helpful to help you guys monitor how hard they're working. If you get nothing else, heart rate is really important, and practicing the walking tasks. If you can do that safely without a harness, awesome. If you can't, work on that treadmill, because we see really impaired people here with Berg balance scales of half of them are less than 5. And that's a lot of patients with a lot of neurological impairment. Outpatient, gait belts, if you don't have them, those are really important as well. You can have you compared this to? No, because people don't walk underwater. It's cheaper than doing underwater treadmills, just a regular treadmill. So I guess if I want to make it more similar to what they're going to have to do in the real world. So we don't do the air bubbles because I can just hold them up. We don't do the water treadmills. We don't have any robotic devices here because people relax. We are just pushing them really hard. There are some things that might be helpful that perturb people more. Like Shirley and I both have this in our clinics now, a balance tutor. That's a walking device that perturbs people. It's like the old Biodex devices or the Neurocoms, except you're walking. And that may be a really good way to increase the errors and increase their ability to compensate from postural stability challenges. That's exactly the rationale for having that device. It is more costly, and you could probably just push them around, on your own. But having a device that does that in a quantitative, safe way might be helpful. But if you don't have $70,000 and I don't have it lying around in my pocket, I would get a light gate. I'm not supposed to recommend any specific device, but that's the cheap one that I know off the top of my head. We're at 2:15, Shirley. Do you want to keep going, or?
No, I think we'll so thank you very much for the important and inspiring talk. Thank you very much. Does someone want to add something before we end this meeting?
My email I gave before. If you want to yell at me, that's fine too. I get yelled at a lot. There you go.
Thank you very much.
Right. Thanks, guys. Bye-bye.
ביי. תודה לכולם.
תודה שלי, היה מצוין.
תודה רבה.
הפגישה הבאה לקראת סוף נובמבר אנחנו נוציא פרסום, זה מפגש שאורית וסילבי ינהלו.
הייתה הרצאה מצוינת, תודה רבה.
תודה רבה.
תודה רבה.
לילה טוב.
לילה טוב.
לילה טוב.
תודה.
לילה טוב.